Good morning, ladies and gentlemen. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium, and I'm delighted to welcome you to today's webinar. We are joined today by Alix Goss from Imprado, and many of you know Alix from her years of working both at the state level and at the federal level in helping us create a 21st century health data system. In this webinar, Alix is going to share her insights and expertise acquired from her 30+ years as a leader in the industry. Her leadership roles including developing national healthcare standards, implementing and complying with federal and state regulations, and aligning business strategies, systems integration, and operations management in both public and private sectors. Alix is passionate about enabling healthier and more productive people by strengthening organizations' public policies and national standards. Alix was appointed to and served on the National Committee of Vital and Health Statistics, the public advisory body to the Secretary of Health and Human Services, and the Health Insurance Portability and Accountability Act as part of support for that act, among other activities that the National Committee on Vital and Health Statistics supports. Alix is recognized for her involvement and leadership of game-changing initiatives that improve the United States health system, and received the Weedy Lewis Sullivan Award honoring individuals who have distinguished themselves through their leadership, vision, and achievements in advancing healthcare. As I move forward through various slides in the presentation, I first want to introduce you briefly to today's webinar and some of the rules of the road. Feel free to use social media. We've provided you with a handle for MHDC, Alix's organizational affiliation, Imprado Consults, and event hashtags if you choose to use them. Rules of the road. We're recording this presentation. Please be mindful of that. Say nothing that you wouldn't want to be on the public record, as we would say. All attendees will be muted during the presentation, so please enter your chat in the Q&A window. Chat's disabled, so questions that you have should be put in the Q&A window. Lastly, we'll take a moment prior to the completion of the poll so that we can understand your assessment, your perspectives, and continue to improve the presentations, interviews, webinars, and other events we provide to the community. Next page, please. Very briefly, for those of you who don't know MHDC, we are an unusual organization. We've been in business for 43 years. We serve all parties in the healthcare data ecosystem, the healthcare data economy. We bring regulatory and health data standards expertise. We have a strong local focus, but a national influence. And we've prided ourselves on finding ways to solve problems at scale with solutions that knit together many of the complex technologies that are going to be necessary to make interoperability, information sharing, and a more patient-centered health data economy work. And so with that, I would like to turn this over to my friend and colleague, Alix Goss. Alix, welcome to the Massachusetts Health Data Consortium. We're delighted to see you here. You are on mute at present, so let me get you to mute.
And being appropriate attendee at this point, I will take myself off mute and also start to share my screen. So hopefully you are, which screen are you seeing? Are you seeing my slides?
We are seeing your slides.
Awesome.
Perfect.
Thank you so very much, Denny. So let me go ahead and first express my deep appreciation for you inviting me to present today. I was honored to receive your call and to know that you've been watching me in various forums, prompting your interest in having me present today. I'd also like to express my sincere gratitude for this opportunity, as it really prompted me to step back from my typical Speakers Bureau content. I've been recently stomping for standards are sexy and the intersection of clinical and administrative data is now. And I realized as I was talking to Denny and some of your others colleagues in this community of the Massachusetts Health Data Consortium, that there was a broader view of conversation, almost like a TED Talk, that I could offer in this never-ending, changing landscape to give context to our journey for improvement and interoperability. So I'd like to share my approach today, as it may help others as we enter a new era of change and during a period of rapid technology advancements. So I believe that we garner context from our history as it relates to our present and gives us confidence and perspective on the future and our plans for it. And in the context, as you noted, the recognition that I was really touched to receive from WEDI, the Lewis Sullivan Award, reflecting my health IT champion role of my 30 plus years of my career, that we've been through a lot of pivots in the healthcare system during that time. And I've been really fortunate to be in the right place at the right time, supporting my ability to play a role in healthcare ecosystem advances. And I am very passionate about this, as you noted. And from these experiences, I've learned a number of things about how to work with diverse, complex groups within and across organizations, and in some cases across our world, to address barriers and garner consensus on the path forward. And that through these experiences and the collaboration I've had with others, that really a model has emerged for me to underpin success. And these roles that I've played, in addition to the ones you briefly heard from Denny, include deep operations management, being a consultant, a standards developer, a vendor, an enforcement project manager for transactions and code sets for the feds, as well as a state health IT coordinator, a federal advisor, and a convener and a consensus builder. And healthcare is really a team sport. So the reflections I'm going to offer you today are not just mine. They really come out of the collaboration of decades, and most specifically, the collaboration I've had with my imprado teammates. We have over a century of combined experiences for our small consulting firm, and have honed our approach and methodology around transformation and working with people to achieve their intended successes. And this really came out of a lot of our collaborative work within the Commonwealth of Pennsylvania. And by transformation, I mean that there's a recognition of being at a particular place and you want to get to a different place or a different way of being. And it can involve a given strategy, striving for operational efficiencies, or a given project to innovate towards or comply with a particular objective. But let's be clear, all that aside, in healthcare, it's about saving lives and making it better. And I'm a planner. And I know and embrace that no plan survives the first contact. And you'll likely hear me make a few more military references as I work for a Marine, and he's a service disabled veteran. And Dave Grinberg, and he and I have worked together for more than a decade, rolling up our sleeves on initiatives in diverse settings, and have really crafted this framework that I'm going to present for you today. And this model represents and established best practices and learning from doing. In part, we incorporate our lessons and teachings of others, that we recognize that we stand on the shoulders of giants in defining our model and arsenal of tactics to use in supporting organizations in their strategic readiness, operational plans, and cultural ability to respond effectively to the forces, whether they're internal or external. Our model also incorporates boots on the ground, roll up your sleeves lessons. And so today I'm going to give you I'm going to present you a picture of how you can look at your environment, how you can plan and put structure to your organization's culture, language, and approaches to achieving transformation. Each village, to some degree, needs its own lingua franca, and this is the one that we use within imprado. And we all have to be mindful of the eye on the prize and the boots on the ground reality, and to accomplish the strategy and the tactics that effectively link those two together. And to do so takes planning. So just when you think you have a solid plan and a path forward and are ready to execute, reality happens. Regs drop, technology changes, cultural shifts impact business models, world landscape views evolve, and there are other curveballs that happen. How well are you and your village prepared for this? So I'm going to talk about how we prepare for the reality, and with a holistic view, well-being of it, and how to successfully pivot with context and thoughtfulness by planning. And this is all feasible if you've taken the time and invested in your plan, your people, your processes, and your ability to work together. So you've heard a little bit about me already. I'm going to pepper in a few things as we move along, but let's talk about the framework. Let me demystify what I'm speaking about. So the 5 prongs, as I sometimes call them, or components of our framework, are really in the middle of this slide. And they're business, process governance, policy, technology, cultural environment. And these really have emerged from, as I said, our own historical perspectives and lessons learned. That's the bottom layer of the graphic. At the top are what this is really all about. It's the focus of the people, whether we're the workers or we're the patient, or the care delivery mechanisms. And it's the village at the top, the people in the village that really is the focus. And we have the critical bookends of trust and transformation at either end. And these really encapsulate altogether our framework. So you've heard several times that I've worked in the healthcare field for more than 30 years. And my passion for improving healthcare really started back in high school when I was volunteering as a candy striper at Emerson Hospital. For those of you who are in Massachusetts, you'll know that that's in Concord. And I was also born at this same hospital. And carrying several years of eye-opening hospital experiences forward, in the late 80s, I graduated from college with a degree in public administration and a focus on labor relations. And through good fortune, I had landed a position when I graduated from college as a management trainee and in the Medicare Part B division of a very large Blue plan. And this meant spending 6 months of Medicare, learning all aspects of the Medicare operations, from the mailroom all the way to post-payment functions and all the ancillary operational and technology services. Upon completion of this, I became a 6-month program. I became a supervisor in the appeals unit before moving into staff consulting roles, blending federal regulations, systems integrations, and organizational efficiencies. This has really taught me in my first 15 years of my career to think enterprise while appreciating the depth and breadth and value of the discrete pieces that come together to crank the wheel of supporting Medicare beneficiaries in receiving and covering care. Further, I learned the value of the people that perform the functions that crank the wheel. Their nuanced perspectives and ability to contribute insights are key to achieving change, learning from others, appreciating the past experiences, and blending views and perspectives to design the path forward. Transformation, change management, call it what you will. So let's dive in a little bit to set some historical context on the need for humans to communicate and to do so in a way that others understand and can receive, process, and use the information being sent or transmitted. The point being that the need to communicate and do so effectively has been evolving for a very long time, and that there is tremendous interplay across all the components of the model that we'll talk about in this cause and effect aspect. But let's give us some step back for a second, and I apologize for this eye chart, but I wanted to give you kind of a snapshot. If you think about telecom, hardware storage, software standards, health insurance, health policy, these are all part of our iterative efforts that we've been taking for centuries. And I've at the bottom provided a bit of context just to kind of ground all of us. But let's start out with the telecom, this ability to communicate with one another. And I think we're all probably familiar with the siege of Troy, but let's not focus on the Trojan horse at this point. What I'd like to really do is elevate the fact that there was this aspect of fire signals that were used at the siege of Troy in 1200 BC. We needed, for political reasons, war reasons, limited resources, and other human needs, this ability to communicate. So we used fire signals in the 1200 BC timeframe. You leapfrog forward to 150 BC, the Greek historian Polybus converts the Greek alphabet to numeric. This gives us the ability to actually encode texts so we can signal them. Leapfrogging way forward to 1608, the telescope was invented, enabling ships at sea to use signal flags. That's really not that long ago. But even more approximately, in 1889, Almond Stauder invents the first direct dial telephone system, bypassing the need for manual processing. That's just 100 years before I graduated from college. In 1946, 250,000 switchboard operators were enabling public service and businesses to communicate with one another. And in 1991, the World Wide Web took shape, really truly transforming our ability to communicate. Now that we've got this context about wiring and key infrastructure, and the fact that we've kind of built over time on the advances that have happened, let's look at the aspects of computers. So from a hardware and storage perspective, in 1921, Babbage's engine is invented. This is known as the first mechanical computer, and really enabled automatic calculating engine. 1951, we got the first commercial tape drive, low cost, relatively, with portability and unlimited offline capacity. And then in 1970, IBM switched us from magnetic core memory technology to using semiconductor technology. But for computers to help us and for telecom to carry our information, we need languages and specifications on how to use them for a given purpose. Software and Standards in 1944 took a major leap forward with Samuel Morse using his new Morse code to send the first telegraph message, "What hath God wrought?" between DC and Baltimore. In 1893, building on the thoughtfulness of Florence Nightingale's from the 1960s, the French physician in 1893 introduced the classification of causes of death. This really gave us the framework for the International Classification of Diseases in 1893. And many of us are still reeling from the ICD-10 implementation, and ICD-11 is right around the corner and is an even major transformation, more so than today. From a software perspective, many of us are probably familiar with the common business-oriented language affectionately referred to as COBOL that some thought wouldn't survive, but yet is probably, since its 1960 deployment, has really provided a major engine for business. And in 1997, we even had estimated over 200 billion lines of COBOL that were accounting for 80% of all business software code. It's still in use today. Leapfrogging from COBOL's launch in 1960, in 1963, the American Standard Code for Information Exchange, affectionately called ASCII, permitted machines for different manufacturers to actually exchange data. It was kind of limited with its 128 unique strings and only ability to represent 256 symbols, but it gave us a huge leap forward. 1972 came the C programming language. And I think I'd like to call out here three particular standards bodies when they were chartered by the American National Standards Institute. So NCPDP, the National Council for Prescription Drug Programs, 1977. X12, 1979. 1987 brought us Health Level 7 or HL7. In 1988, we got the XML recommendation from W3C. And in 2011, HL7's Fast Healthcare Interoperability Resources was born and really makes it easier to leverage modern web technologies in exchanging health information. And it's just hit its 10-year birthday. But to help us with financial aspects, both the liabilities and the revenues of healthcare, let's talk about health insurance and health policy. In health insurance, we've been on an interesting journey since Teddy Roosevelt proposed universal health care on the campaign trail in 1912. In the 1920s, the US hospital, Baylor, started to offer prepaid services for sales, the precursor to the Blue Cross plans. And this was also seen by them not only as a way to help their patients, but also a way to guarantee steady revenue streams. In the 1930s and 40s, the New Deal took shape, advancing a lot of our national dialogue around national health insurance. In 1939, physicians started to organize the first Blue Shield plan to cover the cost of physician care. In the 1950s, large corporations started to offer insurances as part of their benefit packages, including health insurance. And in 1960, the Federal Employees Health Benefit Plan initiated the health insurance for federal workers. And in 1965, Medicare and Medicaid. I think we all are probably pretty familiar with that notable advancement in our society. When we look at health policy, it's about protecting, serving, normalizing, and sustaining our framework for interoperating. And we've written, debated, and commented and adopted health policy in a lot of ways. And I'm just on this row, I am just focusing on on 20 years, from HIPAA to Medicare modernization, to high tech and meaningful use days, to the Affordable Care Act, to the impact framework to help our seniors, and MACRA to continue to advance our overall Medicare access and SHIP reauthorization, and the landmark 21st Century Cures in 2016. This has given us a tremendous number of provisions that push for greater interoperability, adoption of electronic health records, and support for human service programs. At the bottom, you'll notice that context row that I mentioned before. And I really want to call out the fact that there are cultural aspects of our great gaming and TV and movies and books that really also impact our culture and the way we think about the services, the technologies, the opportunities that we have as citizens. And you look at how Star Trek has really informed flip phones. And I thought it was really cool when I got to play with Pong. And then you see leapfrog forward to 1999 with the Matrix, and in 2010 the iPad launching. So what does this historical context really tell us? Well, it tells us that we've rapidly progressed in recent decades in harnessing technology to digitize and automate efforts we've been working on for centuries. Communicating and doing so efficiently is a constantly evolving framework that has many implications and thus is complex, especially when it's about the health of our citizens. There are a couple aspects that I kind of want to throw out there before I dive into the detailed portions of the model. Some of these are general overarching thoughts that speaks to the importance of strong leadership, good documentation, and valuing cross-functional teams. First, you really need to think about this holistically. Even though the components have their own discrete journeys, they're overlapping journeys, and they have interplay that needs to be considered because they have ramifications. Whenever we're applying a model, you need to do it in context, and that some degree, people always think that their situation in a given organization is unique. And sometimes that's really true. Often it's not. There's a lot more in common than not in our approaches to things. However, we really need to respect that uniqueness and validate the complexity of transforming a healthcare system and the delivery and paying for it in an appropriate context. Organizations that think in silos will be sunk because there is really no redo button or silver bullet in all of this. You really have to have discipline, practice, and iterative learning, because this does take a village, and we need to be humble and open-minded. And so I think it's at this point, I want to stop for a moment and ask Denny if we're good so far, if you've gotten any questions, or you'd like to pose a thought to me.
There we go. I need to unmute myself. We're doing great, Alex. You're doing great. I appreciate it. A couple of questions and a couple of thoughts that I think you bring to the fore, which is, when we talk about healthcare, sometimes we talk about it as an industry, we talk about it as a social good, but it's really an economy. I mean, when you think about the number of industries that are actually involved, it supersedes and encompasses multiple industries, and as such, I think is the 5th or 6th largest economy on the globe. in and of itself. If we floated it out to sea, it would be the sixth largest GDP among all the economies in the world. And the approach that you're presenting strikes me as mindful of that, we go into a village where people have multiple perspectives, they have different points of view, payers have priorities, providers have priorities, regulators have priorities, services organizations, associations, we could go through the list. And change, as you and I talked about before, is something that is really a constant in healthcare. We see it in seemingly sudden jolts or spurts of activity, especially now. We've been in the business for some time, and this is a very exciting time, but it's important to keep in mind that it's not the first, nor will it be the last. And I appreciate your sharing that. Could you comment a little bit on, and I'm sure you'll be covering this more as we get into discussion, but culture and environment are enormous forces in implementing change, in developing and implementing new business models. I don't want to jump ahead, but I'm always curious about culture eating all of our good work for lunch on a regular basis. And maybe you could just either talk now or a little bit later as we get into the presentation about the great challenges that are imposed by culture and the environment.
Yeah, definitely. I will be. I have 2 slides on that very topic.
Good.
Describe it, and one to actually talk about some of the challenges. But I think across all of what you've just said is trust, and that's why it's one of our bookends, because strategy and versus reality, boots on the ground, day in, day out, the complexity that we have when we want to try to improve our system. At the same time, we're trying to take care of Susie Q, the patient, who is the one I often use in my facilitation. And she's quite a sick individual, and she needs our help. And from all the different capacities that we play as citizens in the healthcare ecosystem and in the big business that healthcare is, what binds us together is the need to make it better for each other and to continually be present to the feedback loops that we're getting so that we can continue to evolve, because it is all about those people and the villages, the cultural aspects of wanting to live good quality lives. And I think that there'll be various pieces throughout this presentation in describing the 5 core components today that will really help underscore your question and the importance of really stepping back and thinking about this is big money, big business, big important juju to take care of the people that we love. And how do we balance all of that? All of this is a balancing act, and it takes trust to bind it all together.
Thank you.
You're welcome. All right, so let's now dive in a little bit. So Denny and I are going to interplay like this is periodically. So what I'm going to do is cover a component, describe it, address some challenges to it, and then then Denny will break in and we'll have a little dialogue. So please be sure to put your questions in the Q&A box. Let me dive in a little bit more now to the first one, business. So I cut my teeth in Medicare operations and eagerly took on this role because of it was going to help the elderly. And the social mission was important, but the population group more so for me. And unfortunately, I came to realize, as we've just kind of discussed, that healthcare is really a big business. And that was a little hard for me to accept because I thought it was about motherhood and apple pie. But we really have a healthcare system that struggles with sick care versus healthcare. And insurance was developed to pay for care that was too expensive for individuals to bear for themselves. And there was an aspect of sustainable revenues in all of this. And computers came to the insurance side well before it came to the treatment side of the house. And so we ended up with technology that was more about the treatment, payment, and operations aspect and only later tackled the clinical tools that we were going to need and the models that focus on how to keep people from getting sick in the first place. And so we not only have TPO to worry about, but we have all those downstream implications, research, public health, that are needed, that need the data that comes out of that provider-patient experience. And there are a lot of direct and indirect players within the healthcare system that need to be thought about. And the categories of actors, if we talk about just the ones that have a direct role in healthcare, we have patients, providers, payers that are direct delivery mechanisms. And of the payers, we have public payers and we have private payers. When we talk about providers, we have inpatient, outpatient, behavioral health, lab, for instance, and more. And then we have the other folks that don't necessarily have a direct role in delivering the healthcare, but we need to think about their views of things as we're making change, because many different types of organizations contribute to delivering care and pay for it, but the responsibilities and interests often overlap. They also sometimes conflict. So this starts to create this idea of a tension in the system that we see in a variety of places. For instance, the provider wishing to deliver the best care that the patient wants, but the payers interested in avoiding unnecessary care. To make matters more complicated, there are different types of these players. So even though you may have inpatient and outpatients, labs and RADs and behavioral health providers, you also have multitudes of them. And then we have this in-network and out-of-network complexity for the patients to sort of manage. And while it is critical to consider any proposed changes through the lens of direct players, the new state has to really be operational and think about those indirect payers, especially as we start to think about more well care, not just sick care, and all of the social determinants of health aspects. And we'll talk a little bit more about that as on a subsequent component. But I've kind of covered these first three bullets, the diversity of players and the multifaceted data needs that they may have. But now let's talk about the last three bullets in this slide. It's really covering the cost. It's about models, and it's about covering the cost of healthcare services being a challenging topic. And models for coverage payment include public and private insurance plans, out-of-pocket, cash and debt liability, as well as uncompensated care. Models evolve to fit a particular need and meet the incentives that are available. And sometimes we have conflicting short-term and long-term incentives, especially when it comes to preventative care. In addition to this aspect, companies' purpose and structure influence its behavior. Some entities are expected to generate profits for stakeholders, whereas other ones are expected to improve and serve and improve society. Beyond the revenue model aspects, organizational size and focus has an impact. Over time, an organization's size can change, impacting the behaviors and strategies that are needed to sustain success. Insurance got a boost when employers used it as a way to attract employees during the World War II wage freeze. But when the freeze is abated, employers continued and expanded the use of benefits to attract and retain employees. We're seeing it happen today. But as the cost of health insurance increased, both employers and employees found themselves trapped. But because employees change employers, because Medicare and Medicaid grew up to cover those who were not employed or needed a safety net, each payer gained a short-term focus, which is antithetical to the long-term return of investments, such as preventative and chronic care maintenance would call for. But to further complicate the matters, insurance entities have many flavors. They're commercial payers that administer government programs, commercial payers that administer self-insured businesses programs, and they're government payers. And by the way, all of these are large employers in and of themselves. Quite simply, the interests of stake shareholders are distinct from the interests of both organizations. The people who work for those organizations and the organization's customers also have to deal with a different set of regulatory rules depending on which hat they're wearing. I noted the size and evolving shape of organizations before, and I think it's important to understand that, as we probably all do, that smaller businesses tend to be more agile, but have fewer resources. Larger businesses have more resources, but they have a lot more hoops to jump through and allocating those resources and deciding the competing priorities, especially when it's a state or federal government. And regardless of all the size and flavors of what your business is about and how you're focused, whether it's revenues, social service, patient-centric, everyone needs to know who is their customer, the person who is receiving the care or the entity that's paying for the care. As you grow in size, the mix of customers may distract you from your focus on the patient. As organizations grow, so does their complexities in administration, and thus there may be a new customer to add to the mix, which is my boss. So sending some description around the business component, let's talk about some of the challenges to transformation. I mentioned that I worked in Medicare, and at one point I was one of a handful of people that was designated to represent CMS at X12, the standards body that from which HIPAA adopted 7 transactions from claim to remittance. And I spent time building standards, and this expanded my view more than I would have anticipated on the critical balancing act that must be done to find the art of compromise and the path forward. And evolutionary threats create definitively a resistance to change. And both people and organizations respond to environmental dynamics as a survival technique. Behavior in first blush may not truly reflect the end goal intent. Change resistance comes from a variety of places. Individuals may resist change out of fear of the unknown or of losing relevancy. And organizations resistant to change protect their source of profits, and in the case of public sector organizations, their reason for existing. Employment from inefficiencies is something that is actually fueling that GDP reference that Denny started to introduce. And let me put a little bit more number to that conversation about this. Almost 17% of our GDP is tied to the healthcare industry. And it's not insubstantial piece of that is having employees do redundant or inefficient tasks across organizations, and really could call for more automation. When we look at the hospitals, like I noted that the insurance companies are often large employers, hospitals are often the largest employer in rural communities. So if we fix all these inefficiencies, what do we do with all the people who will lose their job potentially? But pivoting from those who are doing to the data, who owns the data? How do we use it? There's a conflict between where the data is stored and who has access to it versus how they can use it versus getting to decide what the permitted uses are about it. Data in today's market is the revenue fuel in our economy, and it is a healthcare economy. And possession, as some would say, is 9/10 of the law. Unfortunately, organizations have used data in their possession for things that individuals would disagree with. But if the businesses aren't permitted to use the data and profit generating, why should they make the effort to collect it, store it, and harness it? So we have some challenges with some short-term and some long-term dynamics related to revenues. And all of this really comes also down to our ability to compete in the marketplace while also being collaborators. And if we want to transform the healthcare system, we really have to cooperate with one another. But we have to do that in a way that doesn't run into antitrust. So let me pause and ask Denny if we have any questions.
We do have questions.
Okay.
From me, I think what you raised is one of the fundamental challenges of the purpose of healthcare. And as you pointed out, efficiency comes with considerable costs, and questions arise as to are healthcare organizations, especially providers in the communities where they're the largest employers or among the largest employers in those communities. Hospitals and health systems have acted as one of the greatest accelerants to individuals moving up the economic ladder within their communities, starting in entry-level jobs and moving through. I know a number of people who've spent 25, 30, 35 years in a single healthcare organization and started out working in the lab and ended up being the top of the organization. Could you talk a little bit? It's a big topic and I don't want to take us off track, but at some point we're going to have to find a balance between the social good that healthcare organizations serve as employment and economic development engines and what constitutes efficient and effective use of the premium dollar from wherever it comes. Can you just address a little bit how you see that balance kind of moving in the future, where you see there being compromises on one side or concessions on the other? How is that going to advance as far as your thinking is concerned?
That's a great question. So if I think about the healthcare continuum and the conversation we're having now, what I've seen, especially when you look at the Affordable Care Act and the medical loss ratio aspects, and you think about now bolting on social determinants of health and how communities are helping to help assist people living in place longer, we have a whole new wave of transformation to happen as we start to harness our new technologies, our new exchange capabilities. My mother has a device in her heart that communicates with the device next to her bed so that her cardiologist can monitor her. If we didn't have the technology in 2012 that we did, my mom probably wouldn't be here today. But there's also the aspect of, we want to live in place, we want people to have independence, but we want them to be safe. And so how do we best use our premium dollars to enable people to live in place longer, to start to address the zip code disparities that we have, and really start to level the playing field on what is well-being? Because if we're all healthy and functioning and contributing, then we can raise all the ships up and then be a better system overall. And so that iterative learning, hopefully, and leveraging the technology, the cultural aspects, the policy frameworks of how we want to be treated as humans, will hopefully let us use those premium dollars over time more to really get down to that level of, what does Susie Q as a person in her unique situation, in her zip code, with her genetics, with her life choices, what's really going to resonate with her to let her be the most optimal person that she can be? And I think we've worked from HIPAA to get our arms around administrative financial to high tech and subsequent, Affordable Care Act and a couple things to really harness this idea of patient-centric models with the patient at the center, to the 21st century cures about really getting to that level of engagement by freeing the data and sharing it. There's a whole new wave coming at us about how to really harness and best use those premium dollars. And I think it's important especially when you think about the state budget dollars and how we all feel about our taxes and how well they're being used to achieve that safety net for the communities, for the citizens that don't have the access and capacity to pay for good healthcare or even get good quality food.
We have another question about, can you provide some tips about how to manage the balance needed to compromise effectively in organizations or across organizations where there are so many competing claims? I mean, how do you find, what are some of the ways in which you have what's your toolkit? What do you pull out in the back of your mind and say, this is a compromise moment. I need to ground these people in a shared, what they agree to, and move from there? Or what is it that you do to deal with the competition among different claims by different constituencies and their relative importance?
Well, that's an awesome question. And that is about process, governance, and the art of execution. Sometimes it's about just laying yourself out there and having a conversation. And this is kind of giving me flashbacks to the days when we used to go to ballrooms. We'd be in big hotels, negotiating strategy or standards, or discussing a proposed rule from the feds. And there are hidden agendas everywhere. And those who pony up to your table may not really be there to help. They may be there to learn and undermine downstream, because we've got people who want to protect their business models. And sometimes all you can do is be consistent, transparent, be willing to be humble and vulnerable, and call people out. But sometimes you have to call them out publicly, not the best strategy. It's better to get to know people, to have relationships. And a number of these points I'm going to cover on the process and governance component that we're about to get into. This is a balancing act of experience and having a lot of different tools for stakeholder engagement and relationship management. And sometimes that's surveying to start to take the universe from here down to here, to then have a refinement process. It's about being transparent and open, to garner the trust that you need to work through those really tough conversations. And you also have to accept that sometimes you don't always have all the answers, and that you have to learn from other people and be willing to, on the fly, in those stakeholder engagement moments, put the components on a board or on a digital whiteboard and help people focus in on where you can find the agreement. And in the process of working with people, you will reveal those hidden agendas. And you can then, through really hard listening and reflection, you can find a path forward. There are times, for instance, when I joined the Governor's Office of Healthcare Reform in the Commonwealth of Pennsylvania, I was hired to work on a statewide infrastructure that was needed for the administration's reform objectives. And above my appreciation of the Plan, Do, Study, Act methodology that we had as part of our chronic care initiatives, I was really focused on the HIE effort, and we had some very bumpy early days, including a failed attempt and a challenged procurement. And through some very transparent, stepwise processes and good governance, we were able to reframe the HIE initiative, garnering so much collaboration and consensus that the legislation for Pennsylvania's HIE journey passed unanimously in both chambers of the legislature, enabling us to really act on the consensus-based recommendation to stand up an independent agency to administer Pennsylvania's HIE model, which is a network of networks. And so even when it looks darkest, go back to process and good governance, you can find your way through to the other side. In just a short hand.
Well, I think you're reinforcing the trust bookend. It's essential. I think it's always best to retreat to the truth, as you indicate, and it's gratifying when we see that in others with whom we work, in that it builds a level of trust and understanding of that person, not just as a representative of a particular constituency, but as a human being. We live in healthcare. We have a second question. We live in healthcare where people are used to working in silos. They're used to working, as you pointed out, some of these are very big businesses and are structured where, departments and divisions and the like create, narrower perspectives by definition, by essence. Have to be good at the component parts if we're going to be good at the whole. But as we move into an interoperable world, data becomes like gasoline. You can differentiate yourself with the automobile, but we all need to, at least currently, use some combination of gas and electricity, both of which are furnished in fairly standard, increasingly accessible ways with respect to electricity, certainly. So as the world moves to this more interoperable healthcare world where data and tools are intertwined, where ownership is an increasingly arcane and antiquated term, an inapplicable term, what are the ways that you've overcome those siloed mentalities, the way that someone who is in development to build the tools that the organization needs, someone who is in data to help standardize the data that the systems are going to use, and someone who is in operations or policy who may say, you know, these data need to be protected. We can't share them. These are organizational assets. Yet all three of those have to come to an agreement, and many more than just those three. Could you talk a little bit about some of the ways you overcome that siloed thinking? This is a corollary to the other question, but it is very much along the same lines of dealing with the complexity of what we have as an industry or as an economy.
Yeah, and this is great because it really is encapsulating so much of what I want to talk about under process and governance. The cross-functional teams are really important. And that's part of stakeholder engagement and relationship management. So, you know, an experience that I can give you about how I've actually done this, and I learned in the Governor's Office of Healthcare Reform that one of my biggest takeaways was bring the lawyers and the communicators early and often, attach them to your hips, because you need to be able to balance the legal implications, the messaging and the engagement of all the players that need to come together that are across those silos that you mentioned. So that strategy of, you know, having executive leadership, strategic planning, business model, what are we about, where are we going, what are we trying to achieve? Then you separate that from the operational aspects of, okay, so if we want to accomplish this, what are the tactics we're going to need to take on? And sometimes that those tactics involve bringing together projects and that enable operations to function all that much better. So projects are typically innovative efforts, compliance objectives, things that the government's making you do to force your standardization and your ability to play in the ecosystem. But operations is that day in, day out aspect. And when you have project people, operations people with different layers of governance over them, left hand, right hand often gets very disconnected. And I've worked in firms that are very small, 5 people, all the way up to like Highmark, 14,000 people at one point, and the Commonwealth of Pennsylvania as an active, employee. And blending all of that together takes thinking about really takes good communications and thinking about internal as well as external. We often undervalue the need for internal communications, because sometimes, I remember when I was an operations manager and somebody would say, you need to do this. And I'd be like, what the heck? Well, why? It doesn't make any sense to me. But then if I could step back and see the larger picture, if somebody could explain to me what you're doing, Alex, directly goes up and it relates to this strategic objective of our leaders and our organizational mission, then all of a sudden you can start to put it into context. But if you don't have that linkage, you don't have people who can provide that enterprise view and smoothing across all the silos and helping each understand their value and also how they fit in, what they contribute, but also how they fit in, people are going to be frustrated and you're going to disenfranchise your own staff and your own ability to succeed if you're not willing to take the time to explain, enroll, and support not only, and have those relationships. And then, because the other thing about all of this is that finance, we have only so much capital, available, and we need to be sustainable. And capital includes not only financial aspects, but also includes the human power aspect. And if you want to be successful, you really, really have to think about the balancing act there. And then you need to flow down that sort of at least high level understanding to the people in the organization. Otherwise, you're not sure they're really going to be making wise decisions. And the other thing about all of this that I want to touch on, since I'm kind of covering all the process and governance pieces as we talk, is that like when we stood up an independent agency, I mentioned earlier that we had unanimous passage of enabling legislation to harness the $20 million that we had at our fingertips for creating an HIE network infrastructure within the Commonwealth for our 13 million citizens. And we had to stand up a new agency from soup to nuts to govern that. And we'd garnered trust, enabling us to get to that level of legislative passage. And we needed to maintain that trust because we were given authority because they were trusting us, and it was a way to accomplish a bunch of goals and help regional efforts take care of patients and communicate data as patients traverse where they need to go. And we had to provide reasonable assurances to the stakeholders and oversight entities that we were doing the right thing because we had the potential for more than 13 million patients' data to be traversing. And then that was just in-state. And then we had to worry about interstate. And so we needed to set up an organization to govern that had the appropriate culture, internal controls, policies, procedures, trainings, verifications, routine maintenance to really guide our behavior, as well as create commonality across all the various players. And so that involves sometimes independent audits and industry standard assessments. But again, it's about this trust aspect. And in this case, it's trust but verify. I'm hoping I'm
You're doing great. You're doing great. It's a big question. It's a big question. It's a big elephant to eat all at once. And I appreciate one of the better efforts I've seen at doing that for a long time. So I have a few more questions, but I'm going to hold those in abeyance and allow you to continue.
Well, we've done really well on covering. Actually, I wove in to the answer to that question many of the things that you see, bullets that you see on this slide, and I think I
noticed that was I was impressed. You kind of hit on every bullet point while you were answering the question. So,
my problem here today is not it's staying within the boundaries of the time that we have available, because I'm trying to synthesize down so much content into a nuanced kind of like PowerPoint for everyone to take, not as in the application, but the powerful point that I want you to take away from all of this. And there's one last thing I'd like to say about on this slide before I talk about some of the challenges of processing governance. And it was an experience that I had in the early days of creating the Pennsylvania Health Information Exchange. And I remember the director of our office calling a meeting, inviting all the people that we thought would sue us. Everybody who was gonna take pot shots at us, from the ACLU to the law projects to patient advocates. And I was nervous going into that meeting, and I'm glad I wasn't leading that meeting. And a very skilled woman facilitated a discussion. We laid out what we were trying to do, why we were trying to do it, what we thought we could achieve, and that we, quite frankly, wanted to know what they thought about it and what did they see was the problem with it. And what we walked out with was completely unexpected to me, which was we had just garnered our biggest champion. We just garnered people who said, finally, you're going to help get the data where it needs to be so that the compromised individual can be held, supported through their health journey. And we're for you, but you need to do this in certain ways because there's a lot of nuance, there's a lot of fear, there's a lot of challenges with technology and transportation and all kinds of other aspects in healthcare delivery system, especially when you are a highly compromised or disabled individual. And so just when you think you're not going to have support, sometimes if you just step back and say, why won't you like this? What do you think of this? Engage in a conversation. You'll be surprised what you get. People are more good-hearted and willing to roll up their sleeves and bring their experiences to bear in helping to solve a bigger problem And if you're humble enough to recognize that you've just got this piece of the puzzle and that there are all these other pieces that need to come together, it can really work. But it takes good process and governance. It takes reflection along the way. And it takes being willing to say, I don't know, or I was wrong, and learn from others.
Well, and we've seen that those others can often be, as you pointed out, the champions that we needed most and didn't know that that was where we would find them.
Yeah.
You know, we're going to need those champions as we get through social determinants of health, because from some very, very good and very caring organizations, the concept of social determinants of health comes with enormous risks to the patients, either in terms of siloing them in circumstances that they may be able to change. It may result in diversions to less effective care. We don't know, but we can only find out if we ask the community. And sometimes they, in all likelihood, they thought about these issues a lot more than we have. And that's why we need to ask them. And I think that's a terrific anecdote to share. You never know who your friends are. And you know who your enemies are. You think you do, but you never know that some of them are actually just on the edge of being your friends. And I think that's a very good lesson to learn. And we need all the help we can get.
Well, and collaboration to me is, I want to get stuff done and I want to do it well. I am humbled by how much I don't know. And I need others to help design things. And the power of what you can get out of a group discussion, to me, is just, I've been doing this for 30 years. It's awe-inspiring. When you just think you can't climb that mountain any further, and then all of a sudden, the peak appears and the heavens open. And
there you have it, right?
Yeah. So let's talk a little bit more about some of the challenges that we have in process and governance. And, you know, I'm really proud that my work and my professional career is a very bipartisan topic. I've spanned 3 administrations at the state level and 2 federal administrations as an advisor to the Secretary of HHS. And I've seen inertia to leadership changes in a variety of ways. And this is not just limited to the government environments. It's really about if the workers don't think that the initiative is going to outlast the current leader, commitment can be faked and feet can be dragged. Buy-in is really critical. And part of the reason why I think the roles about stakeholder engagement, relationship management, planning, and communications that we discussed just a moment ago are so critical. I also think that the discipline and cultural integration, the executive leadership's willing to define the methods and the value of having and using technology and where we all fit in that journey is really critical. And so if you don't have strong leadership and you don't have forced integration, cultural integration to help everybody understand all the pieces of the puzzle and why we do what we do, it's likely to fail. In the midst of all of our just trying to do our daily business, we have regulations that come at us. And the reality of many implementations is that we're checking a box. We're not living up to the spirit. We read the reg, our requirements, our resources are so limited that we just, what do we have to do to get this done, to check the box and move on, when federal policy is really trying, and state policy is really trying to embody a spirit of expectation of it we should be all living up to. And so we have a nonstop competing priority balancing act that we're going through. And so from some time consideration, Denny, let's hold on this question after the process and governance, and let's do a next round under policy, if that's okay with you.
That's fine.
Okay, thank you. You know, I've been called a policy wonk more often than not, and could have spent my time on this topic today. And policy to me is really important because it stitches us together and binds us to a norm of behavior, like our technology standards link computers and devices. And being a good partner in our society needs rules of the road, and policy really sets the rules. And so the policy setting is not done in a vacuum. And during my time as a National Committee on Vital and Health Statistics, or NCVHS federal advisor to the Secretary of HHS, I was honored to learn from so many of the brightest in our industry and beyond the healthcare industry as we asked them questions, listened to their views and insights, and synthesized and analyzed their input to craft recommendations. And we also watched and learned from the implementations of the subsequent output that came from those regulations being adopted. This type of transparent process of engagement is highly reproducible and invites and garners trust in our communities. They're key to policymaking, but only if we all participate in it. And policy is very diverse. It's multifaceted. It's a balancing act of needing to protect the data and sharing the data that aligns with patient preferences and permitted uses. So, this involves security of the physical, cyber threat, intellectual property, and data governance. It also involves consent, the citizen's right to own and control their data. And their data may be shared among covered entities, but that also brings some other challenges because sometimes the data goes to places where they aren't covered entities. So we have different rules, different laws that supersede some of the basic rights to protect the data from misuse and misharm. And so we've evolved over time for the individual protections from the fair information principles way back in the 70s that have been advanced in the United States and internationally. And ONC has really harnessed a lot of those principles in their 8 components or their 8 principles approach of individual access, correction, openness and transparency, individual choice, collection use, disclosure limitations, data integrity, safeguards and accountability. And these 8 philosophical approaches, it can be assessed within any organization, and you can think about what they mean to you in the context of your work and actually establish policy so that you can, eyes wide open, make choices about how you're going to interact with the data and how you're going to behave. And this is an example of, we have many policy levels in organizations, businesses, we have them at state, regional levels, we have them at the national and international levels. And so we need to think about how all of these policies work together and, even take shape in trying to address nefarious actors and making sure that people aren't holding the data inappropriately for their business model preferences over that of the citizens' well-being. So we have a lot of different interests that are competing, and all of us wear many hats. We're a citizen, we're a patient, we're an employee, we play a community and cultural role. Some of us are additionally providers or healthcare policy makers. And so it's important to analyze the conflicts that can be inherent in our own roles and recognize those as we're really coming to the policy making table. And that ultimately trust can be enabled through frameworks and standards. And they're really necessary to ensure interoperability because one size fits all is a difficult thing to try to achieve in a complicated environment. And to try to deal with the different related interests, but often disconnected interests that are seen along the way to interoperability. From a policy challenges perspective, we have some challenges just within who's on first within the federal government. And we're starting to see the Office of National Coordinator really embrace this and try to help bring clarity of who's on first and how the unique needs of the federal agency or their unique roles that they play in advancing national policy really need to be coordinated. Because siloed activities within designated authorities complicates our policy development. And we have to think about what applies in which situation and who governs which scenario and which policy and reg do I need to go look at to think about the implications. I mean, it's a Lawyers Employment Act to some degree. And congressional laws wreak havoc on when we're just trying to make everything work. They're forcing evolution on us, and then we have to, those laws then take shape as regulations, and then we have to make them work. But then we have to all work together and make sure that as we're collaborating to build challenges, standards, we're really not tripping into any antitrust aspects. So there's this sort of interesting aspect of tentacles that happens in policymaking and the forced standardization and behavioral normalization. We're striving for these greater efficiencies and effective approaches within our available resources. And not all parties see value in a common approach. But the frameworks that can be employed, such as TEFCA or certification programs, can really help us achieve that kind of normalization that really helps us along the journey to interoperability and an improved healthcare system. We also, quite frankly, have the new flavor of equity, and what are we going to do about it? How are we going to fix it as we move forward with social determinants of health? So I think it's a new playing field that we need to pay attention to, and then it's going to be a hallmark, a transformation, I think, that we're facing right now. Policy also has a challenge with moving slower than business or technology. And I think it's natural that it does so. Technology and business pushes the envelope, and policy by nature is much more conservative. And then you've got people involved, and, that we often have policy trying to catch up to where we want to be or how we're actually being in operations. But sometimes this creates disconnects. And as we're trying to balance day in, day out delivery of healthcare and compliance, the federal layers are also in their own balancing act of, the wide continuum, trying to advance policies because one size doesn't always fit all, and the cost and the value of recommending something. So it's another reason why we should all be seriously paying attention to proposed rulemaking, because we need to help them understand the boots on the ground reality as we try to keep the eye on the prize of interoperability and transformation. So a big part of this also comes back to policy-based challenges to trust, include unintended consequences, hidden agendas, and this visceral reaction we may have for policy attempting to drive change versus reacting to it. And that change only happens at the speed of trust. And trust and transparency have really become hallmark components of our current day culture. And we need to know that our leaders are acting in good faith, and we need to have the reasonable assurances and the level of transparency to be willing to understand what people's interests and motives are about and how we fit in and how we effectively balance all of it. So let me stop there and see if you have any questions before I move on to technology, because I do have two more components to get through.
We do have a question. How do you balance playing all of these different roles? As one example, you may have wants and needs as a patient that conflict with the interests, needs, wants of your provider, of your health plan. Do you recommend just being aware of the current hat that you're wearing, or talking out and working through these conflicts as part of the process? Sometimes we recognize that we need to compromise. At what point in the journey from this is my way and this is your way, do we get to a point where we have some agreement? Do you just stay in your role and press your case, or do you act in a conciliatory or bridging fashion to bring about some compromise?
I had a boss a number of years ago when I was a EDI publisher of standards, and I was managing the transactions and code set complaint system for HIPAA for CMS. And at the same time, I was the chair of the insurance subcommittee of X12. And so we would literally have conversations where we would change positions because my boss at times was my worker bee. And so we would literally, in a meeting, we would say, okay, move. No, I'm over here. Now I'm playing this role. I know, because you have to be extremely mindful, and you have to be willing to be called out. And if you're not willing to be called out, you're probably not being aware of your own biases. And so there's definitely a need for, I've seen even like the propeller heads, like we maybe need to get one that has the different, we can turn our hats around. So we can, today we're wearing this hat, then this hat, because I am always a person. And I come with my experiences. I come with my passions from my past. I come for the commitments and goals of my family and our well-being and my community, my chosen family, as well as my given family. And I wanted to work for them. And so that's where being humble, being collaborative, having good relationships, and being willing to step back and reflect on it is really important. And it's constant awareness of that. And healthcare may be almost 17% of our GDP, but it is a pretty small world when it comes to those who are trying to transform healthcare. And so if you run the conference circuit, we used to we'd leave one, hey, see you next week, there's a core group of people that are moving along and moving us through the process. And through those relationships, we can also then garner more awareness of what hat we're wearing. We can also appreciate, hey, that person works for the Hospital Association. That person works for the Blues Association. You start to have to understand people come with their particular hat that they're employed to defend, advance. And that sometimes that makes people have little wonky behavior, because I've worked with people who are equally deeply passionate about improving healthcare. And I have found working with them confusing, because sometimes they're speaking from their heart, and sometimes they're speaking from their jobs, and sometimes they're speaking from, I don't know. And so when you're in conversation with people, they're, even in the moment, they will change on you. And sometimes that leads to being confused in the process. And all you can do is just call it out. Be real, put it on the table, and figure it out. And use process and good governance to get there.
Thank you.
So I'm going to move on to technology, because we are, at this point, we were trying to be under an hour and a half, and we're going to be pushing the envelope there. So let me talk about technology. And technology touches and pulls together a lot of pieces to bringing efficiencies and functions. And it's often easier part of any of our transformation projects. The reality of people and their workflows, workflow change management is harder in technology deployments, is something I've really garnered appreciation for, whether I was in my Medicare or my HIE work. And I've even seen it more recently with some of the work that I've done for HL7's Da Vinci project in leveraging my experiences of implementing HIPAA and meaningful use, and being able to put together this concept of blending business operations and technology roles to help successfully deploy a standard and get value from it. And so we have a multitude of functions and investments over decades that we've made, and those technology advancements have increased power while also decreasing costs. And application programming interfaces, or APIs, as FHIR is going to be really enabling in our healthcare economy, and as we've seen adopted under 21st century cures related regulations, they really are coming to healthcare, even though they've been used in industries for a number of years. And it's introducing the next, what I think is the bridge to our next way of harnessing technology, but we have a long way to go in being able to really maximize the use of that standard, because we've already made a lot of investments in standards. And when I talk about standards in this context, I've already talked about policy. That's one kind of standard. But there's another type of standards that I'm really thinking about here, which is about that transport, the structure and the semantics. If you think about the context slide about the computers, the ability to move the data across the wires, to be able to have it be computer processable by its structure, and to have a language that we can trust. These are really important components of trying to harness a technology project. And it's often difficult to harmonize all of these standards because different segments of our industry have different granularity needs. And so coming up with standards can be a very messy process. And a lot of folks pay to argue at the standards development organizations. So those who show up and participate in the development clearly have the better ability to influence the outcome and ensure that their use of standards is going to meet their needs as they move forward, and also to bring their experiences to bear in helping others build a better product. As these part of the data movement and the technology infrastructure, people have made choices about architectures at the enterprise solution data and storage level for a very long time. And they've had to do that within the context of their immediate purpose. And sometimes we've centralized data, which has its pros and cons. Sometimes we're moving much more to a federated environment by not putting all of our eggs in one basket, giving us some better security capabilities, some better efficiencies. But each of these models, architecture models, considerations have implications, not only for right now and how we use our resources and what we do, but they bind us or enable us downstream. As we work with the data to harness our ability to do our jobs, we're using technology to really process and get value out of the data. And that really comes mostly from a structured environment. Machine learning and artificial intelligence, natural language processing are really advancing rapidly and getting better at interpreting plain text, but we still have a long way to go. And we have a lot of old data, existing data, and infrastructures that we're going to have to reconcile as we move forward. Dirty data is really something that's going to be challenging to us as we move forward, and the workflows that go with it. But I'll talk more about that as I move forward. As we think, when I was cutting my teeth in Medicare operations for 15 years, I worked on a lot of projects, and we did most of that in the early days with in-house development staff. And then we moved more into getting vended products and then integrating them. And then we started to outsource more of our solutions over time. And, we have software as a service and platform as a service approaches that have really evolved. So as we're trying to evolve our healthcare sphere, the technology sphere is also evolving. And that has a lot of implications for the development, for our workforce, educational needs moving forward. And we also have the really critical risk in front of us of the cybersecurity and what can happen to the data, the breaches, and there's so much risk from leakages of data and bad actors, and even just some unintended, consequences that happen from people's behaviors. So if we think about some of this flavor of technology, let's talk a little bit more about the challenges. And so, technology cannot solve problems that are fundamental to the other categories. Technology is our best patching agent that we've had, that we were deploying. And if you think about just identity management as an example, and for time consideration, I'm not going to even go into that any further, but identity management. We do a lot of effort to reconcile individual identity, which is really a policy-driven problem currently, because we can reconcile it if we want to. But there are, I mentioned earlier the lack of common workflows on dirty data and normalizing human behavior, how we interact with people, how we type data into systems and applications, how it's shared across settings and functions and products is complex. And it's going to be, along with inequities and social determinant of health aspects, I think another big focus for us moving forward. One size does not fit all. We've had a lot of challenges with our EHRs that we try to build products and roll them out, and different settings call for different tools in the toolbox and have different nuances, reporting obligations, information capture needs. And so we've rapidly digitized data, evolved our technology front, and along the way, we've memorialized a lot of inconsistent workflows and processes. And so I think that we're going to have some pain points as we move forward with that, as well as the backwards compatibility issues with the newer and older systems that we have. I really hope that FHIR can help us bridge some of that. I'm a firm believer that, you know, we've got HIPAA and we've got high tech, and we've now got 21st century cures. You'll notice I use the word "and" in all of that, meaning that we have to bridge all of this together, and we have to think about, as we move forward, not creating unintended consequences from our major transformations on our ability to actually harness what we've already invested in. And so as we move forward, we will also have the ongoing data stewardship and trust aspect with using the data, ensuring it's correct in the way we're interpreting and applying it. So that gives you a flavor of the technology aspects. Before I move into culture, maybe I should stop, Denny, and see if you want to ask me a question at this point. You're on mute.
I'm going to wait, Alex, and let you continue, because I have 4 questions here that I think are probably best served after the presentation. So I'll let you continue.
All right. Well, so we're going to bring it into the home stretch and talk about culture and environment. You know, value is really based upon your perch and the needs that you have. And I've mentioned before that we're citizens, we're patients, we're employees, we're taxpayers. So we wear all of these hats, and we have to think about those hats and the motives that they bring in our various conversations. And I think we had a great Q&A on that. So let's talk a little bit more about the insurance-based healthcare system versus a healthcare as a utility or as a public good. And this is a part of our big debate that we're having nationally, as the US healthcare system is not, is insurance-based, systems benefit, and it's not available and affordable to all. And so government programs provide the safety net. And the objective of private businesses is, more often than not, return of investment or profit. And this goal is misaligned with or even in conflict with patient welfare. And so further, because the insurer is paying for the care, the insurer is the customer at times, not the patient. And so we have this cost quality conundrum tied back to our 17% of our US GDP, in that we're spending a lot of money and we're doing a lot of awesome innovation, but to what degree are we willing to accept a higher cost in their system for innovation, but yet not get the degree of quality outcomes that we can see being achieved in other economies across the globe. As we are trying to address our cost quality conundrum and our social equity aspects, we also have a constantly evolving diseases and the understanding of the diseases. I'd like to just think sequencing the genome, and how we are really advancing a learning-based, or trying to advance a learning-based health system, because not everybody may be about an evidence-based medicine, but it really is rapidly evolving as we understand, as the technology aids our ability to tackle microscopic level of genomic consideration on our diseases and what that means for treatments that will come out on the other side of all of our learning. And so we also have to think, as we're doing these genomic kind of assessments, and we're looking at what kind of treatments can be, and we're looking at social determinants of health, and I'm calling it the evolution revolution these days. We know that our zip code can impact our status of well-being, and more so than our genetic predisposition. And thinking about inequality, accessibility, lifestyle, homelessness, transportation, food deserts, employment levels, education levels, there's really also an aspect of thinking about stigma and our generational aspects, as well as cultural norms, citizen views, and approaches to psychological aspects of health still carries, our mental well-being still carries a stigma talking about it. And we're evolving on that cultural front as we really tackle mental health, behavioral health, substance abuse, and body type issues, and how our technology, our policies, and our business models all come together to impact that. And our processes and good governance can help us really manage our way through this journey and addressing some of the cultural and environmental challenges that we have. Healthcare is slow to adopt technology and policy advances. We've had opportunities to do it on our own, like the banking industry, but really it just didn't happen because the incentives weren't there to enable it to happen. Industry is very driven by reacting to, and yet frustrated by reacting to, rulemaking. And we can talk a little bit more about that. From industry wants to drive, but sometimes is unwilling to just make it happen. And because of the complexities that we've talked here today about in various places and pieces and parts. There's also, while we've got business and cultural aspects of technology adoption, we have generational shifts and evolving expectations of citizens within a given age bracket and then across the generations that make the variances even more challenging to get our arms around. And experience with technology, education, and the lessons from the past will also influence the generational views. Policymakers are often, more frankly, the older generation that's already walked a lot of the journey, whereas those that are doing the day in, day out operational aspects are often the younger folks, and there needs to be a robust listening across the different generations, because we need to learn from each other to be able to design something that's going to work better for us longer term. And this really encapsulates our ability to tackle economic inequalities and system-wide impacts and to engender trust while really embracing political, race, and gender aspects in our overall conversation. Because we are competitive, but we're also cooperative industry, and I've really seen that level of cooperation evolve as we've seen. We go work on standards collaboration now at the beginning. It's not where we go in the end. And I think the transformation under the FHIR-based economy, API economy, has really shown that. So my call to action for all of you is that this framework that I've described is enabling us as individuals in our respective numerous villages of our community to embrace the complexity and multidimensional aspect of trying to transform a healthcare industry that is in motion, yet needs to alter its trajectory to a different endpoint while still delivering the critical day in and day out care that needs to be provided while we're learning. If we can embrace as an ecosystem a model of conversation or language around the complexity and dimensions that need to be balanced and continue to evolve those as we evolve, we can maybe get there a lot more pleasantly. Ultimately, we can create a framework that lets us interoperate as human beings, just trying to make it all better. So please transform carefully, because our lives depend upon it. So with that, thank you.
Alix, that was fantastic. Thank you for the elephant and for making it possible for us to look at it and to understand it, and to, I think, especially respect, the interpersonal and intersubjective things that are often not visible when we're talking with folks around the table, that through trust and through conversations we can understand more effectively. It seems to me true that the more we do this work, the more we realize that it's all about the relationships with the people who help us get there, that we can't do this on our own. We have a number of questions, and I want to be sure we get to them, and we'll have a poll in just a moment also. But let me start with the questions that we put together. You describe, we have a regulatory environment that is on one end pushing for an API-based approach to health data exchange. And we have on another side, the sort of revitalization and push for the trusted exchange framework and the common agreement, which are two very different ways of moving data. One can look at that as confusing, or one can look at that as practical. And an effort to meet the industry where it is, given that these technology changes are so difficult and that the path to transformation is so fraught. Could you talk a little bit about, do you see these efforts on the part of CMS and ONC as complementary, as ways to bring more of the industry into a data sharing mindset, or do you see them as competitive or contradictory?
Yeah,
probably is a better word.
It's interesting because part of my work on the Fire at Scale Task Force, I'm beyond the executive committee and transition work group as it's going to be moving into the HL7 accelerator program for a longer term governance model. I also sit as the co-lead with Bob Dieterle on the directory version and scale Tiger team, which is really trying to figure out, like, how do you know who's who in the zoo and where do you find their endpoint to share stuff with them? And how do we make this scalable and manage the versions? And this idea of, you've got TEFCA, which is very much based, which is like the modern, HIE version of a clearinghouse. It's not an and. It's not an or, it's an and. Because businesses, governments, policy have made choices about how to exchange information. And they will continue to make choices that are specific to their situation, their goals, the money available, the time to do it, their limitations, et cetera. And so as we look at, HIPAA gave us a covered entity actor of a clearinghouse. We didn't, HIPAA was almost a dirty word when we went into electronic health record landscape. So then what happened is we incubated clinical data exchange, and we called that more HIEs. So now you've got clearinghouses and HIEs, but in reality, they're intermediaries. They are the way we can get data from our structure to another structure, and we can either create point-to-point, which we can do under an API world, or even in an API world, we can put somebody in the middle. We might have multiple hops along the way. The thing is that you can't tell businesses and leaders and innovative product vendors, you can't tell them which way to go. They have to choose. So that, and all of this that I didn't bring up is still market forces that will play. And so folks will make choices and they have implications. And, we still have people who are doing 1,500 claim forms for professional services, not an 837 professional electronic transaction, but they're paying somebody to take their 1,500 claim form and turn it into an 837 and send it over to the payer so they get their money back. People are doing that in all kinds of different funky ways that works for them. So I think it's an opportunity for transformation on the horizon. How do you make the intermediary models all work well and effectively together when you've got EDI and APIs? And you've got such historical investments in EDI, and you've got lots of people who really are bridging gaps and really see the power of APIs from a longer term workforce efficiency and deploying services and products. Those are going to have to live together for a very long time. And we're going to have plenty of an opportunity to stitch it together. And as we've seen, Marianne Yeager and her team at Sequoia are taking that on with TEFCA, with the Qualified Health Information Network, and the ability to say, we're going to start here, just like we did with ONC's Nationwide Interoperability Roadmap. We're going to focus on clinical care. And then we're going to bring in the next layer. And so what they've done in the QHIN technical framework is they've taken on what we're doing today with the IHE standards and health information capacity to exchange information. And they're going to bolt on Fire next. They're going to have to take it iterative wise, as we all are going to have to do it within our own strategic and operational plans.
Thank you. That's a really good answer to that question. One that struck me initially as, wait, this is contradictory, but I realized maybe not as quickly as I would like that we have to meet organizations where they are and provide a path to getting from where they are to the future that they can accommodate. At the same time, with a sufficient amount of hopefully market pressure, not just regulatory pressure, but hopefully market pressure bringing up the back. Another question that I have is here on COVID and the effect that COVID has had on what is already a fraught and complex technical, cultural, personal transformation, a journey. And suddenly we are beset with a plague. Priorities have been turned on their heads. Can you talk a little bit about managing change under especially aversive circumstances like this pandemic?
Yeah, it's been really interesting to see people really all of a sudden recognize just how duct taped together we have let our public health infrastructure become. It drives me nuts. As a state HIT coordinator and as somebody who sat on a National Committee for Vital and Health Statistics, I've spent a lot of time looking at birth to cradle and the data and how we use that. And so when we got into the public health pandemic with COVID, it revealed it to the world. And it also provided us, as everything is a balancing act, it provided us with the necessary incentives to really step back and try to chart a different path forward. And we're investing a lot in the public health infrastructure now as a result of it. We saw HITAC, ONC's Health Information Technology Advisory Committee take on a special effort this past spring to really look at what are the public health recommendations that we can move forward with as a result of what we've learned from the pandemic, and how does that fit in with our other trajectory towards an efficient health IT system in the United States that links also globally, because we have to think at that level. And so I think it has, in one vein, helped us understand the downstream data needs better and why we need that surveillance. I also think it's helped people sort of reset their what's important gauges. And I think that we all have taken also a step back and reflected on just how powerful it is to be in the room together. That you can debate a standard, you can debate a policy, you can debate a data element, and you can fight like cats and dogs. And then yet you can come out of that room of debate with a little expanded horizon of thinking, and then go to dinner. And then, oh, poof, on the back of that napkin, out comes a solution. And so I think that the pandemic has maybe helped break down some old issues, provided some new refreshed clarity about what's important. And I think hopefully is helping us understand the power of collaboration, all that way.
Terrific. I have one final question. And before I ask that question, I'm going to launch our poll, ask folks to please take a moment to respond to the poll and put your perspectives as to the kinds of...
I hope I just didn't I thought I was getting rid of it. I hope I just didn't mess up your poll.
I don't know, I see it. It looks like it's okay. I'm gonna relaunch it. Let's see if that's okay.
Okay.
Here we go.
Sorry. I was thinking I should take it, so I thought I was closing it out. My apologies.
That's okay. We can fix that. We're doing fine. We're doing excellent. Again, those of you who have access to the poll, thank you for your input. We're about 60% of the way through there. Everybody, I believe, is online from looking at the screen. So
I think it's there are a lot of competing priorities out there. So I'm happy that folks attended today. It's kind of a philosophical, abstract conversation, and that I hope that will give people fodder to think about and apply in their own environments. Every situation is unique, but yet there are things that we can garner from others to help improve our own discrete journey.
Well, we're all in the weeds, Alex. I mean, it's very difficult to raise our heads from the work that we have in front of us, and to have a framework as you've presented and posited is essential. Otherwise, we end up thrashing around trying to find solutions to our own problems without the kind of vision or perspective that a framework like this brings. I have one last question to pop at you, and this can be a short answer, a long answer, whatever you would prefer. Among the big transformational initiatives that are going to be thrust upon the industry is going to thrust upon itself. The economy is going to thrust upon itself. What do you think are the 2 or 3 big ones that are going to be at the top of the list in terms of success stories, biggest transformational efforts in, say, the next 3 years? If you were to look at all the things that are being juggled in the air, and you were to say, if I were to bet on which 2 or 3 are going to rise to the top, what do you think those would be?
I think that HL7's FHIR, Fast Healthcare Interoperability Resources standard, is going to help rally a community, continue to address some of the shortcomings that we've seen under HIPAA and meaningful use and the Affordable Care Act, really testing, vetting standards to a high level of degree of rigor before we promulgate them. I think it is also enabling industry to come together and lean in together to create that collaboration as the floor, as opposed to where we go when we have no more answers. I think that it will help us with bridging the old world of investments to the new world. I think it will help us with a lighter weight development touch for engaging communities and social determinants of health. So I'm going to put my eggs in that one basket for you this morning, to say that I think from an HL7 FHIR perspective, from a global healthcare perspective, we are going to make notable advances in the next 3 to 5 years on the standards and the capabilities to exchange data and to get those exchanges to happen in a faster, more efficient build out. And in parallel to FHIR, we're going to have to really bolster our workforce. So I was really pleased to see that some of the federal funding is going to workforce development, because we've got to help our people understand the current opportunities and to have the right skills to crank the wheel, to apply their experiences and their nuances of learning and doing, and to help the process and the overall governance be as strong as it can.
I like that one. I think we lean the same way. Alix Goss, Vice President and Senior Consultant from Imprado, and an industry policymaker, change master, facilitator. I've watched you work in many contexts. I think you do marvelous work, and you bring your own self to the work, which I think is one of the ways in which we get to know people and get to trust people, is that we get to know them. And I'm delighted to have you today. We want to have you back. We want to find out how things are going and what you're working on and how those changes are happening. But it's with great pleasure that I thank you for joining us today. And on behalf of our community, on behalf of the Health Data Consortium and myself, I want to thank you and our audience for great questions, for a topic and a deck that I would like to have with me all the time, to remind me that there are places I need to look, that my own limited vision might keep me from seeing. And having a framework such as this, especially one that does no harm, as you've described, is a very, an essential part to what we do. And it must have been an exceptional thinking exercise to put that together. I think of the chart with starting with the Trojan War and how we progressed from there, which is impressive to say the least. And I very much appreciate the effort you put into elevating our thinking. And I want to thank you again, and thank everyone in our audience. Any final words, Alex, before we adjourn?
Thank you, and link arms with your partners. It can help.
Thank you very much, Alex. And thanks to everybody who's joined us today. Stay well. We have a nice spring day here in the Boston area. Spring day, it's October. What am I saying? See, I've lost track of the time already. And with that, we're adjourned. Thank you very much. Bye-bye.